I was asked in a Facebook dental group about why to use the Kois Dental Facial Analyzer, and so I thought I'd make a mini lecture about it. But the more I thought about it, what's more important? Well, the most important thing to us as restorative dentists is when we enter the operatory to deliver restorations, we want it to go as smoothly as possible. So why take a chance? By simply making a simple change, utilizing a Kois Dental Facial Analyzer, we can improve our outcomes. Because what is occlusion? Well, it's tooth contacts, isn't it? And why should we be concerned? Well, again, as I said, ease of insertion. By limiting our adjustment time, we reduce our stress. And in the patient's mind, we increase our value of skill. We improve our reputation. And at the end of the day, we increase our profit and busyness. Again, how do we do this? Well, we have to use the tools, but more importantly, we have to understand why we're using those tools, and that's what I want to talk about a little bit. We, of course, know that facebows and the Kois Dental Facial Analyzer can be used to help us with aesthetics. We can use it to transfer the interpupillary line or the true horizontal plane of the patient for aesthetics. I happen to like the true horizontal plane, so I just put a bubble level on my Kois bow. And why do we want to do this? Well, the reason is because to get proper facial and dental aesthetics, we need to be aware and communicate to our technicians the pitch, yaw, and roll. And by using a facebow mounting, we are mounting our aesthetic plane to that of the top of the instrument. So the technician knows that the top of the instrument is our aesthetic plane. They will also drop a perpendicular from the top of the instrument, and that will make the midline. If you mount incorrectly, you're going to end up with a midline cant, and that's going to be unesthetic, and you'll have a failure on your hands. But what I want to talk about for the moment really is the occlusion, what's happening at the posterior teeth. And we know that if we have lateral interferences, especially in a parafunctioning patient, this can result in stress on the restoration and stress on the teeth. And these lateral interferences have been shown to not only cause failure of restorations, but fracture of intact natural teeth. So we want to try to limit those. We need to understand what articulators do and don't do for us. Understand a positive error occurs when the articulator undercompensates for mandibular movement. And this results in a positive feature on the occlusal surface where that feature should be smaller or non-existent. In other words, think of a cusp that's in the wrong place or too high. And when the patient grinds side to side, either runs into that cusp or it's going to have to move the jaw around it, so we need to adjust it. Now, a negative error occurs when our instruments overcompensate for mandibular movement, resulting in a negative feature which allows the posterior teeth to disclude more freely. In other words, you have a groove placed so the opposing tooth can pass through, eliminating these potentially damaging shear forces. So what did Kois do? Well, Kois, on a number of patients, took a Panadin facebow. And then he derived an arbitrary transverse horizontal axis and measured the distance to the maxillary central incisal edge and found it to be about 100 millimeters. And this was true for about 90% of the participants. Now, what's interesting about this 100 millimeters is what it actually translates to compared to, say, a cephalometric tracing. And Lux did exactly that. She took cephalometric radiographs, also mounted with a Panadin as well as a Kois Dental Facial Analyzer, and measured the distance from the articular center to the incisal edge position. And this is what she found. The cephalometric X-ray distance averaged about 90 millimeters. Interestingly enough, the Panadin and the Kois Dental Facial Analyzer measured almost the same, 95 millimeter distance. They were further away from the rotational center. Well, what does this mean to us, at least using an articulator? Well, it falls into proximity rules. We know just by simple geometric, compass drawings that the position of the tooth and its distance from the rotational center will affect the ridge groove direction. And so the further away we get from the rotational centers, and that's what the Kois bow did as well as the conventional facebow, the more obtuse the angle between working and non-working grooves become. This is creating negative error. There's less likely to be interference when we return to the patient's mouth. Think about it this way. This is a better way to visualize it. Think of a mandible, all right? And then many of us use simple instruments like clackers. They're very, very common. But let's look at the rotational pathways. If we draw a radius from the rotational center of the condyle, and draw a tangent to that, that'll be our pathway excursion. Well, what about if we use this clacker? And again, it depends on how this clacker is mounted relative to the models, whether you're using a quadrant or full arch. But take a look at the rotational pathway drawn from the tangent. So if you pick the wrong instrument, you can actually create a positive error that necessitates a lot of adjustment at chair side. And this is not fun. We did something really fun at the VA West Los Angeles. We took patients, we located kinematic axis with a facebow, mounted their casts. We also used a Coist dental facial analyzer and mounted those casts. And then we drilled holes in the center of the first molar and put a lead pencil, lead in it with spring loaded, and then traced working and non-working pathways on a piece of graph paper. And the reason these graphed markings on the right have a tail is for reference, and we opened the articulator, so rather than a Gothic arch, it's just a reference Y shape. Now, we then overlaid those pathway tracings with different colors, kinematic in red, Coist in blue. The interesting thing is when you overlay them, note something. Again, the angle between working and non-working pathways is more obtuse with the Coist mounting. It has created a little bit of negative error. And we found that the Coist dental facial analyzer resulted in negative error in all the samples that we reviewed. So when we utilize tools, we not only have to have an endpoint in mind, we have to understand what they do and don't do for us. So this is going to be a vertical dimension case. And again, I started and I did this segmentally. This is how most of dentistry is done. I started with the lowers and completed the lowers. I opened the vertical and I got my correct occlusal plane. I came back later and I did my maxillary anteriors. I set up my lines, my disclusion. And I finally came back and finished some of the maxillary posterior teeth. I did not complete the second molars. I will do that at a later time. But I want you to note the topography of the teeth. Look how nice they look. Okay, this is why we want to set up occlusion and how we can set it up without any stress, utilizing instruments, but more importantly, understanding why we're using those instruments. So think about it. Do you want to continue doing things the way you're doing with the argument that you're just too busy to make a change? By simply incorporating a facebow, which really shouldn't take any more than 5 minutes, I can assure you that you're not only going to have more predictable deliveries, they're going to be less stressful, go smoother, and you'll be happier with a happier patient. Think about it.